Good morning, everyone. And I'm very happy to be back with our friends and good colleagues in Hawaii and happy to be with you today. And again, a huge thank you to all of the sponsors that have been involved in this project. We greatly appreciate their support. Kathy and I have already been introduced, so I'm not going to spend time doing that. I'm going to dive right into the reason we're all here today. And we have some webinar objectives. You always have to have those. We're going to talk about the early signs, risk factors, and how dementia presents in adults with IED. We're going to talk about screening for the onset of dementia, talk about some approaches to care across the different stages of dementia. And then we're going to talk about some specific activities and how do you support people as their needs change. And as always, we have to have the medical disclaimer. Please don't, rely on anything we say. Kathy and I like to think that we know a lot in this field. We've got probably over 80 years of combined experience, but we're not clinicians. So never disregard any advice that we give. Rely on your own physicians and seek medical treatment. Don't rely on anything you have heard in the workshop. So I am going to talk about risks, early signs, screening, and assessment of dementia. And, why are we talking about this? Well, we're talking about it because this is a growing population and is such a growing concern. It wasn't all that many years ago, or it isn't to me anyway, given my age, but back in the 1940s, people with Down syndrome didn't live that long. 9 years of age was the expectancy back then. Fast forward to today, and thanks to advances in healthcare, primarily, cardiovascular system issues and infection control, people are now living to be almost 60 years of age, which is a wonderful thing. But there is a bit of a double-edged sword. Particularly for people with Down syndrome, that has brought with it a greatly increased risk for developing Alzheimer's disease, and we'll talk specifically about that in a minute. The good news is, in addition to people with Down syndrome living longer, we're also seeing the same increased longevity for people with other forms of ID, cerebral palsy, autism, fetal alcohol syndrome, any of the other forms of ID. And we're also seeing that they're living longer as well, too, which again is a wonderful thing, but it does bring with it the increased risk for developing some form of dementia as you age. Why do people with Down syndrome have such a higher risk of developing Alzheimer's disease? And it's really because of that third copy of chromosome 21, and that's the gene that carries the amyloid precursor protein, APP for short. And it's that protein that's overproduced in people with Down syndrome because they have that third copy of it. They get a kind of an extra load of that. And it's that protein that causes those amyloid plaques to form in the brain. And if you've heard about Alzheimer's disease, you oftentimes hear reference to plaques and tangles. And it is that protein that causes those plaques and tangles. And by the age of 40, if we were to do a scan of people with Down syndrome of their brains, we would see those plaques and tangles present by the age of 40. But I want you to understand, just because those plaques and tangles are present at age 40 does not automatically mean that everyone with Down syndrome is going to develop those symptoms. There is a greatly increased risk, but not everyone with Down syndrome will develop Alzheimer's disease. Now, having said that, a substantial proportion will. By the age of 40 to 49, estimates are, national studies show anywhere from 23 to 55% of people with Down syndrome will develop Alzheimer's. By the age of 60, 50 to 70%, and by the age of 70, 75 to 88%, and a lifetime risk of 90%. But that's not 100%. So it's important to remember that there are certainly some people with Down syndrome who do not go on to develop Alzheimer's disease. Why is that? Wish we knew. There are studies ongoing to try and figure that out, but at this point, we don't have a good answer for that. When we look at the general population, you see that people with Down syndrome develop Alzheimer's at a much younger age. For people in the general population, over the age of 65 is the greatest risk. There are some people who develop Alzheimer's younger than 65. My own father was one of those people. He was 56 when he was diagnosed. But the vast majority don't develop Alzheimer's until mid to late 60s and 70s and beyond. But that's not true for people with Down syndrome. They develop Alzheimer's much younger, in their early 50s. And so the point here that I want to make is that for people with Down syndrome, Alzheimer's, the symptoms typically occur anywhere from 20 to 30 years earlier than they do in the general population. And you may ask, what about people with other forms of intellectual disabilities? And I wish I could tell you more than I do. The bulk of the research money that goes into studying intellectual disabilities and dementia goes into the Down syndrome population because they do have that increased risk. There's very little funding that goes into studying people with autism and whether they have an increased risk, or people with cerebral palsy or other forms of ID. And if you look at studies, they're not conclusive. You'll find some studies that say they have an increased risk, but you'll find other studies that say they don't have an increased risk. So I think the best we can say is they may have an elevated risk. Diagnosing dementia, whether it's due to Alzheimer's disease or some other cause, is greatly complicated because people with ID oftentimes have lifelong communication challenges, and they don't have the same access to specialized assessment that people in the neurotypical population have. And they oftentimes have other co-occurring medical conditions that can kind of make the picture more fuzzy and more difficult to tease out. Is it some form of dementia versus an underlying medical condition? But research is ongoing, and my hope is that we will learn more as time goes on, and we'll have a better handle on really what the risk is for people with other forms of intellectual disabilities. But regardless of the form of intellectual disability, the first question you always have to ask is this really Alzheimer's disease? When we see someone with an intellectual disability aging and we see a change in their function, we should never assume that Alzheimer's disease is the cause. There are many, many potentially treatable conditions that can present with the same symptoms that look so much like Alzheimer's disease, but in fact could potentially be treatable. And I'll tell you what some of those are in a minute. But our job as family members, service providers, advocates, whatever it is to make sure that first and foremost, all potentially treatable or modifiable conditions are ruled out first. The diagnosis of Alzheimer's, or just that generic term, dementia, should never be made on the basis of one office visit. It's a diagnosis of exclusion, and that means ruling out any potentially treatable or irreversible other conditions that can be causing those symptoms. And there are many of them. This is just a short list. Hypothyroidism, for instance, B12 deficiency, infections, diabetes, sleep apnea. If you have sleep apnea and you go without oxygen in your brain periodically throughout the night, that can cause cognitive impairment. If you have hearing or vision problems and they're not properly corrected and you can't see or hear the world around you properly, that can cause you to look confused to the point where someone might think you are having, changes in your cognition. Even pain can cause cognitive changes. Depression sometimes is called pseudo-dementia, meaning sort of fake dementia. And people who are severely depressed can display many of the symptoms that look so much like Alzheimer's disease. Anxiety, grief reactions, particularly for people with Down syndrome, who often express grief differently than you or I might. Depression and grief reactions can sometimes cause a change in their ability to function, which, if we don't do our due diligence, could get written off as, well, they're in their 50s and they have Down syndrome, so it must be the onset of Alzheimer's disease, when in fact depression is a treatable condition. Medication side effects. People with intellectual disabilities are oftentimes on many, many medications. I was dealing with a family member yesterday who's on multiple medications and very high doses of those medications. And that polypharmacy, as it's called, can have a significant impact on how people are able to function. And all medications have side effects and drug interactions. So medication effects have to be ruled out. Is there something in the environment or something, some significant life change, such as a death in the family or even a change in a staff member that maybe has worked with an individual for many, many years? That loss and trauma that can result from those sort of significant life changes and the isolation. Think about COVID. And we saw a lot of changes in people with intellectual disabilities during that time, changes in their ability to function. And many times it was related to the isolation that came from COVID and not being able to get out and do the activities that they had been so used to doing and not understanding why they couldn't do that anymore. And there's a condition called delirium, and this is a sudden change that occurs, within hours or maybe a couple of days. The person was whatever their normal self was yesterday, and this morning they either don't want to get up out of bed at all, they don't want to eat, they don't want to talk, they just want to sleep all day, or conversely, they maybe are very agitated and pacing around, maybe with clenched fists, or they fluctuate between the two. Alzheimer's and those other forms of dementia come on very slowly and insidiously over a course of months and years. Delirium, on the other hand, comes on very, very suddenly and rapidly. And delirium is a medical emergency. There can be many causes for it. Urinary tract infections, one of the most common, pneumonia, or think about COVID, fecal impactions. You can get really sick from a fecal impaction. Many other potential causes, but it's almost always the result of an underlying illness, acute medical condition, maybe medication related, a change in medications, or something along those lines. But delirium, that sudden change, is always a medical emergency. The question always arises, how do we tell the difference between depression and dementia? And so this little table here kind of outlines the differences between the two. Depression comes on oftentimes fairly rapidly. It's triggered by something, be it a death or loss of staff that was particularly close to the person, a change in living arrangement, whereas dementia comes on gradually and insidiously, as I said, over a period of months and years. Depression sometimes fluctuates, whereas dementia is progressive and persistent. It doesn't fluctuate. It doesn't get better. People with depression may complain they can't remember, but for that person with Alzheimer's or another one of those irreversible forms of dementia, they're not even aware they have deficits. Sometimes that comes across that the individual's in denial. And it's not that they're in denial, it's that they legitimately just don't see that something has changed with them. Whereas that person who's depressed does understand, and they may complain that they can't remember anything anymore. Effort. If you ask someone who's depressed a question, they may say, I don't know. They'll make an effort. It may be a poor effort, but they'll make an effort. Whereas a person with dementia may try, but they simply can't make the effort. And mood, depression, persistent sadness, withdrawal, whereas the person with dementia may come and go. They may be sad some days or appear overtly depressed, and other days not so much. But for that person with legitimate depression, it's very persistent. And again, sleep for someone with depression, oftentimes disturbed. They may sleep too much, or they may not be able to sleep at all. For people with dementia, what we more commonly see is that reversal of day and night, where they're waking up in the middle of the night, thinking it's morning and wanting to get up and start the day. Delirium, as I said a minute ago, that's that sudden change. And I really want to stress this point because I see many, many, many times, whether it's people with intellectual disabilities or people in the general population, there's a sudden change in someone's ability to function. And they call their healthcare provider, and the healthcare provider says, oh, they have Alzheimer's or some other form of dementia. It's the progression of the illness. Please do not ever assume that. Delirium is almost always caused by an acute underlying medical condition. And as I said, it's a medical emergency and it can be life-threatening. I have seen people die in my 40 years of doing this who had undiagnosed urinary tract infections that became septic and died from sepsis. So if you see that sudden onset, please do not be tempted to think, oh, they're now developing dementia, or if they already have dementia, it's a progression of their dementia. Something's going on underneath and they need to be medically evaluated immediately. So, here's the underlying problem. How do you know what's changed with someone with intellectual disabilities if you don't know where they started from? That's one of the biggest challenges in identifying dementia for someone with ID, because they have pre-existing cognitive impairments. So that makes standard tests that would be used for you and I if we had memory changes and went to our primary care physician. Those aren't appropriate for people with different forms of ID. Those tests that would be given to you or I are not normed in the population of people with ID. They rely on a certain amount of verbal ability, a certain level of educational attainment. And for many people with intellectual disabilities, they don't have that. And, oftentimes people with ID, maybe they don't have close family. And they may have made several moves over their lifetime to different congregate settings. And so staff maybe doesn't have that really accurate historical knowledge of who that person used to be before these changes happened. And again, so common, when you see those changes, it just gets attributed to, well, they have an underlying disability, or, well, that's what happens to people when they age. So what we'd like to encourage you to do is establish a baseline for an individual with ID before the age of 40. And what you're looking for when you do this is changes from that person's own baseline, who that person used to be. And it will vary by individual because all individuals with ID are different. But you want to look at their memory, cognition, just a fancy word for thinking. How does someone think? Are they forgetting familiar routines? Are they getting lost in familiar places? Are they having trouble learning new information? Are they repeating questions or stories? Language. Are they having trouble finding the right word? Is their vocabulary becoming diminished? They're not using as many words anymore. They're having and assuming that they had verbal ability to begin with. Many people with intellectual disabilities, may not have had that verbal ability. They may have trouble following conversations that they used to be able to do. What about their behavior and their personality? Do they seem more withdrawn? Are they losing interest in activities they used to enjoy? Are they seeming more fearful or anxious? Do they not want to engage in social events that they used to like to do, or go to a day program, or if they're in Special Olympics, don't want to go to those activities? Are they seeming more irritable or agitated than they used to? Have their sleeping patterns changed? Are they seeming more suspicious or paranoid? What about their self-care skills? Are they having problems with previously learned self-care skills? Are they having trouble dressing themselves now, or performing personal care that they used to be able to do, or eating? And are they developing new episodes of incontinence? And for people with Down syndrome specifically, new onset of seizure activity, that can sometimes be a bit of a warning flag that it's the onset of Alzheimer's, and that's specific to people with Down syndrome. But again, you would never leap to that conclusion without doing a thorough medical evaluation. What we'd like to recommend is a tool called the NTG-EDSD, that stands for National Task Group Early Detection Screen for Dementia. And I don't have time today to go into it in detail, but that's okay, because this is a wonderfully intuitive tool that you don't have to be a clinician to do. You could be a family member. It's very intuitive. It's very self-explanatory. All the information is on the NTG website, and I'm going to give you a link to that in just a minute. But what it is it's a screening questionnaire, and it's designed specifically for people with intellectual disabilities. It's free to use. You can download it for free from our website. It's in 18 plus language translation now. And as I said, family members can do it. Certainly professional clinicians can do it. DSPs can do it, and anybody in between. You don't have to have a clinical background to use this tool. I do want to stress this is not a diagnostic tool. You won't get to the end of it and then come up with a score that's going to say, oh, yes, this person has Alzheimer's or some other form of dementia. That's not how it's to be used. It is to identify if there's been a change in the person from their baseline and a way to track those changes over time, and really serves as a communication bridge between caregivers and clinicians. You can take this with you to the physician's office and share it with them so that they can very clearly see what changes have evolved in this individual since the last time you did it. And thanks, Diane, or whoever I see the link is in the chat box. Thank you. As I said, it's on our website. It's free to download, multiple languages. The instructions are all there with it. And there's also a one-page tip sheet for family caregivers. We also have them for physicians and for staff as well, and also for self-advocates. And I did just see that was in the chat box. So, please, when you have a chance, click on that. We suggest the person who completes it be the person who knows the person best. Ideally, they've known them for at least 6 months, but whoever knows the individual best. Again, it could be a family member, it could be staff. If they're in a situation where there are multiple people that are dealing with them throughout the day, it's always good to involve those people as well. And if someone's in a day program, but they go back to a group home or their family home at night, it's a good idea to have the family or the group home do one and the day program do one, because people oftentimes look very different during the day than they do at night. You complete it annually. For someone with Down syndrome, we recommend that you start at least in their mid-30s. For people with other forms of ID, at least at the age of 40. And then you're going to do it annually from then on. So if you start with someone with Down syndrome in their mid-30s, you may go through the screening tool and not find that anything has changed. And that's great. Now you've established your baseline, and you'll do it next year. And you'll look and see, has anything changed since I did it the prior year? And you continue to do it on an annual basis. At some point, you may discover that there are changes appearing. And when you do identify that something's changed in the past year, that's when you want to start looking for further evaluation. So any new concerns, there are multiple domains in the tool. It looks at memory, it looks at behaviors, it looks at sleep patterns, and so forth. When you start to see, and you'll see little check boxes, because they're little boxes you're going to check off as you go through it, indicating if there's a new concern in the past year. And you start seeing those check boxes in multiple areas, then that's kind of the flag waving, something's changed with this person and we need to get it evaluated. If you did previous screens and you're seeing those concerns are now getting worse or more frequent, that would signal the fact that you need more evaluation. And any sudden change, again, I just want to highlight that delirium. If it's a sudden change, first and foremost, medical emergency, rule that out first. You need to think about the EDSD as a conversation starter. It's not the final answer. It's not going to give you the diagnosis, but it's going to help you go to your primary care provider or your specialist or whoever the healthcare provider is that you go to, and start the conversation with them saying, something's changed in this person. Here are the areas that have changed, and then go from there. A good, thorough differential diagnosis, fancy term for an evaluation. There are lots of diseases that have symptoms in common, and a differential diagnosis just teases out, are the symptoms really related to Alzheimer's as opposed to a B12 deficiency or some other problem. You want to get a good history. The primary care provider is going to get a good history from someone who knows the person well. They're going to look at that baseline level of functioning, and that's where sharing the EDSD comes in. And then hopefully they're going to order some testing, blood tests, thyroid, B12, a metabolic panel, a CBC, complete blood count, BUN and creatinine, which are blood urea nitrogen, and creatinine and other liver function tests to see if the kidneys and the liver are filtering toxins out appropriately. They may order a sleep study to see if the individual has sleep apnea, very common in people with Down syndrome. Medication review. Again, people with intellectual disabilities tend to oftentimes be on multiple medications. Could the medications be causing this change in function that we're seeing? As we all age, our bodies don't process medications as effectively. And what may have been a reasonable dosage for someone in their 30s or 40s, now they've reached their late 40s and 50s, and people with Down syndrome in particular have accelerated aging. They physiologically look anywhere from 15 to 20 years older than their chronological age. They maybe aren't processing medications as efficiently. So maybe the dosage needs to be dropped back down. It could be the medications causing these changes in function you're noting. And sensory screening. Do they have vision issues? Have they developed cataracts, glaucoma, macular degeneration? People with Down syndrome have shortened ear canals. Sometimes it could be something as simple as earwax that's the problem. If they have hearing aids, when was the last time it was checked to make sure it's the right level for them? A mental health assessment, meaning, is it potentially depression? Has this person had any significant life events occur in the past year that could have been upsetting for them and caused them to be depressed? Maybe neuropsychological testing. Those are those questions, that oftentimes they can be day-long studies that are done. But those are questions, like, can you count back from 100 by sevens? I'm going to give you 3 words. You need to remember them. We'll talk about something else in a minute. I'm going to come back and ask you what those 3 words were. How many animals that begin with the letter C can you tell me in 60 seconds? Those sorts of things, much more extensive than that, but that gives you a quick picture. There are some that are appropriate for people with IDD, but you want to make sure if those are being done, that the person administering those tests is familiar with tests that are appropriate for people with IDD. Maybe an MRI or a CAT scan. If someone's had a prior MRI or a CAT scan, that's usually better because then you have a baseline to compare it against. You want to assess functional skills, daily living skills. And again, maybe a sleep evaluation, because particularly for people with Down syndrome, sleep apnea is so common. It's really important that we get this diagnosis right. And there's lots of challenges that present themselves for this population. We're talking about people who have pre-existing cognitive impairments. And oftentimes communication is a barrier. They maybe have never been verbal. And so it's hard for them to self-report. We don't have good baselines established for people with IDD. And I'm sure you all know healthcare providers are often very unfamiliar with this population. The diagnostic criteria for dementia was developed for the general population, the neurotypical population, not with an eye towards people with ID who have these pre-existing cognitive impairments. Not a lot of specialists around. And again, caregivers change oftentimes, staff changes, particularly for people who have been in institutional settings or congregate settings, and that historical knowledge is oftentimes lost. So that wraps up my section. I'm going to turn it over to my colleague, and thank you, and look forward to any questions you may have when we get to the end.
Thank you, Catherine. So I'm going to talk about now the stages of loss that occur typically in this disease. And I want to help you give some practical tips, or help give to you practical tips to understand loss is common as a result of the disease. And success for you is making changes to help support that person through those stages of loss, but to also understand the most important part of supporting is keeping the person connected to the world, to keep each individual connected able to be connected to the world, that's a measure of success. And so I'm hoping by taking a practical approach, it will help you visualize that this is part of the disease, not because of the care that you're providing. In fact, if you're keeping the person participating in the skills and being connected to you, that's a measure of success. Next slide, please. So it's important to understand that Alzheimer's disease, the most commonly diagnosed disease of dementia, is a progressive regressive disease over time. That means that there will be loss that'll occur over time, not rapid loss, as Catherine just mentioned. The rapid loss is a sign of some other co-occurring condition often. It's not a rapid loss, it is a loss over time. And so people often talk about care as being stage-based approach to person-centered care for adults with IDD. And so it's important after initial diagnosis to continue treating other lifelong conditions such as diabetes, heart disease, sensory losses such as hearing or visual. And to understand that that baseline that Catherine talked about is so important. And that's why family members, people who have been caregivers for a long time with an individual, are so essential to being able to relate who the person has been, the life story, the essence. And each of you as caregivers, you can collect that story by creating scrapbooks, photo albums, maybe do videos, every so often a video to show how a person is able to participate in activities, the interests of each person, what makes someone laugh, how you can keep supporting so that life is a matter of successful times during each day of being able to keep that person connected to the world and to feeling safe and secure with each of you. So we want to monitor the changes from baseline, which we can do the EDSD that Catherine just talked about, and continue to partner with healthcare providers and other resources. And that EDSD is a great way of communication to be able to support someone during losses. People often talk in different numbers of stages. We prefer to use a kind of simple of 3 stages: the early stage, the middle stage, and the late stage. And we'll talk about a couple of different activities of daily living that people typically perform and how you may have to change the support during each of those stages. And it's not like there's any magic number that after day 65 or day 165, we will be into middle stages. Remember, it's a gradual, slow, progressive loss over time. And again, that's not a sign of any failure of your caregiving. I want you to really understand it's the sign of the brain damage that occurs from the disease. And you being there as a caregiver is so essential. And we hope to give you tips that will help you understand and appreciate the good work that you're doing and how you can use the stage approach to be able to continue to support someone throughout the phases of the disease. Next slide, please. So some of the key highlights, memory care programs adjust support according to the stage of dementia from early to late stages. Catherine talked about the importance of the differential diagnosis, the importance of making sure that underlying conditions and diseases have been addressed when appropriate. And understand people don't lose those co-occurring conditions when this disease occurs. They are also continue to occur and need to be addressed as well. And so knowing that person, know those pre-existing conditions, and knowing how to treat those and working with healthcare providers to help continue to treat other conditions, and never assume everything is from dementia, especially if it's acute. It's happening very quickly because this disease tends to be slow loss over time. In the early stage, care focuses on maintaining independence as much as possible, or really, rather than independence, I like to call it interdependence. autonomy as much as possible through interdependence because we're all interdependent with each person, cognitive engagement, and routine. About 60% of our brain relies on routine and habit to function. If you think for many of us during and after COVID, how confusing, how stressful it might feel because every one of our routines were kind of turned upside down and we had to learn new routines and we had to support the people around us, such as our family members or our friends with IDD. Which was even more challenging, especially if the person now is exhibiting signs of dementia, signs of significant losses over time. And so that whole routine turning upside down has made it really difficult because the brain needs an amount of that information that comes in to be routine so it can attend to that that's novel. Mid-stage care emphasizes daily living assistance, safety, and emotional support, and helping people be present in the moment, helping them to be able to connect to the world and feel safe and comfortable in the world. And for you as a caregiver to feel safe and comfortable as well, and to feel that the support you're providing is helping to make a calm and safe environment. Late stage care prioritizes comprehensive care, comfort, and palliative strategies, again, of that comfort care, trying to keep the person out of pain as much as possible, helping them feel safe in time and space, and helping to be able to continue to connect to the world to perform interdependently activities of daily living that are essential for healthy living. Personalized care plans, specialized therapy, and trained staff are essential for quality dementia care, but personalized care plans for the family caregiver as well. Knowing the person and what is important and what needs to be supported. And with Catholic Charities, other resources, you have just so many resources to turn to that can help you with that knowledge and understanding of dementia capable care. Next slide, please. So, knowing each person for the stage based care, knowing the earlier preferences gives us clues as how we can maintain a healthy activity, such as showering and eating over the course of the disease. I always advise a caregiver's toolbox. I am old enough that I remember when we used to keep recipes in very attractive tin boxes. And I always think kind of that as the recipe box in kind of the old-fashioned way. But thinking of so many people storing data now on computers and in situations when you're providing caregiving, providing support for someone with activities of daily living, support to help them feel safe and comfortable, most of us don't have time to go to the computer and look at the toolbox. So having something that's handy on a sheet of paper of what has worked, what tools are there, what may be helpful for you, and also contact information that you may have or some resource sheets that you've put together that will help you through that moment when you're feeling extra stressed. Having at least annual, and as a person progresses into stages of the diseases, probably could be monthly, could be quarterly, depending how rapid the loss is. This helps you really see the loss and helps you work with healthcare providers as well to determine what is the loss likely from the disease and are there co-occurring conditions we can continue to treat that may be causing the loss. Scrapbooks, life story again, and you can continue to work on them with your family member or the person you're helping support throughout the course of the disease, because that keeps the person connected to the world. And these can be fun activities, creating videos together. They may not appear professional, but they may just be plain fun, but help you give a sense of who the person has been and how this person now that you're seeing who has a disease process is changing, but how do you ensure that you make sure that you are still supporting that person? The medical history in needs in easy to get to and organized places. The physical and sensory environment is as important for you as the caregiver. And so set it up, find simple ways that you can make it easy for you to get to the toolboxes the ways where the information is, and the tools you need to help with activities of daily living. Next slide, please. Back one, please. Thank you. So here's again just a visual of understanding stages. There's a little bit different in the middle one, a little bit different use of terming, but it's the same thing to help understand that it's progressive loss over time. So in the early stages or mild dementia, largely people are able to function as independently or interdependently as they did prior to the disease. Now that's one of the difficulties, little challenges with people with IDD, and why diagnosis and understand what's causing decline becomes a little more complicated is because unless we know that baseline of what the person could do interdependently, we can't tell where the losses are. And that's why that baseline continues to be so important. There is in the beginning, the early stages, the mild dementia, occasional forgetfulness, confusion, and lapses in judgment, maybe making a decision to walk outside without a coat they might never have done earlier in life before this disease process. And so seeing those changes and noting those changes and note what is likely as much as possible from the progression of the disease itself, the brain damage, and are there other underlying conditions, such as if the person walked outside with a coat, even though it's bitter cold outside. Of course, I'm talking to Hawaiians who aren't experiencing the cold we are in the spring right now in the Northeast. But you do have some of your storms and some chilling a little bit, not like we do. But it could be the person has a fever, is feeling so hot that the cool feels better than the heat. And so those judgments, are they environmentally caused? Is there some underlying condition? Especially the more we can understand this in the early stages and find ways to address. As the progression of loss occurs, it helps us to have tools and to think about how we support the person. As they go into kind of the middle stage, moderate dementia, where there may be the requirement for assistance with every daily activity, different from the past when there may have been only moments of the need for assistance. Greater extent of memory loss and other symptoms, including sundowning. Sundowning is what happens in the time of day when it's dusk. And if you're in an organizational facility, often the time of day of change of staff. And sorry, just looking at a message. A great other symptoms that the sundowning is because also the change in lighting and environmental. Again, this may not be as much of an issue in Hawaii because you have more consistent hours of sunlight in Hawaii than we do in the Northeast. But always look to also environmental challenges. Can you increase the lighting in the room? Can you make it calm, or putting on quiet rhythmic music that may be calming to the person and to yourself as well? Maybe saying, okay, we don't have to do this right now, this task. Let's have some iced tea together and sit and watch the birds before we do. It's okay to do that. And that's a sign of success, to have that be a calm moment and a time to relax before performing an activity of daily living, and maybe then finding ways of just enjoying and doing that, making it a fun activity. Severe dementia is what we call late stages. Round-the-clock care may now be required. You may need to ask for more help as a caregiver, more information, more tools that may be available to help as the person requires more care. Maybe loss of ability and difficulty performing functions such as swallowing, and again, looking for what information is available and what help you can have. Next slide, please. So we're going to talk about Jane and her mother's needs as she progresses through the stages. So Jane is a 56-year-old woman with Down syndrome, diagnosed with Alzheimer's disease after a complete differential diagnosis, what Catherine talked about, after that was conducted, currently monitored and treated for her other underlying conditions. She attends a senior daycare program in a community 5 days a week. Next slide, please. So we're going to talk about showering, whether we call it showering, bathing, cleaning, washing up, doesn't matter as much as I want you to think about what is the baseline for each person in bathing and showering. I find the families I work with, the organizations I work with, I'm often called in to help with showering specifically, because by the point of the time that I'm called in to help, it's the time when you usually showers are the major way to wash and stay clean. So let's look at what Jane's baseline capacity was for showering. Jane can't shower herself, including sitting in a chair in the shower. I'm sorry. That should be she can. She sits in a chair, but she's able to shower herself. She has a handheld shower head, and so she is able to shower herself. She's able to place soap on her body as well as use the handheld shower head to rinse the soap off. She does not wash her hair in the shower. She has never liked to get soap and water in her eyes when she's showering. And so she chooses another time with some assistance at the sink to wash her hair at a separate time. Now, this is something important to know about the baseline for Jane. We can't expect that now, after all these years that she washes her hair separate and not in the shower, that now we start to wash her hair in the shower, which is even more frightening and more painful than it was previously when Jane understood that she needed to wash her hair separately. Now she may be getting more confused. Her favorite time for showering is in the early evening after dinner and before bed. These are things to know. Now, if a person is in an organization, a residential setting, it's important that all staff who work with Jane know this, and this is where it's important to have that toolbox. Or in a family, if there are different family members that help with Jane, besides mom, it's important for them to know the time of the day that was preferred before. Now, it may change to a different time of the day, but knowing the baseline gives us clues of when it was preferred before. Knowing that about not washing the hair in the shower is essential. Knowing not to have any water get into her face or soap get into her face, which is something most of us don't like, but knowing for Jane it's even more important. Knowing she has a preference for lavender liquid soap and blue washcloths that match her bathrobe and medium hot water, not extremely hot, but not cool water either. Knowing this helps us set up so there's likely of success. Jane may get to a point she can't communicate this anymore. She may then refuse to shower, but can't tell you why she doesn't want to shower because you've forgotten she likes the lavender liquid soap, or maybe she doesn't like it anymore, and maybe she needs to be able to have a choice of some that you have there for her. Knowing this is important to figure out how together you can help support Jane. Warm towels and clothes for drying, hot tea or cocoa after the shower, and then her favorite TV game show before going to bed has always been Jane's preference. Knowing this and to continue to support it. And the brain that now is being damaged appreciates these because these are comforting habits that the brain can kind of take a rest time as well, because this is something she's done for years and years and makes her feel safe and comfortable and calms her down for hopefully a good night of rest. Next slide, please. So now we're getting mild dementia and showering. So now Jane requires a new chair with arms. The other one is not suiting her. It's gotten kind of worn. It's not comfortable. She needs padding on the seats, making sure the padding is firm and not going to slip so she'll have a fall. She may need a sturdy stool, especially for people with Down syndrome. They tend to be shorter in stature. And so it's sometimes too difficult to find a chair short enough that won't be too short for the feet to touch the floor. So you might need a good sturdy stool, and making sure that you're there with Jane to help her get up and down onto the stool and into the chair. may not have needed this before, but now she may be shrinking a little bit in size and may be far less comfortable. Remember, things like arthritis, osteoporosis also continue. Our aging process doesn't stop. And so it might become more painful. Something that hasn't been painful before may become painful. And that's always something to watch out for. Is it pain that's causing the refusal to shower? And how can you make her feel more comfortable? She may need hand over hand assistance with the shower head and assistance with placing the soap on her body. She may not want someone to put the soap on her body. And so maybe you have some liquid soap that you put on, and she still can do that. So you look for what her previous preferences are and look for what options help her feel support today. I've had people, especially in residential settings with groups, that don't like people to touch them in the shower. They see them as strangers. So it's okay if you wear a t-shirt. If they wear a t-shirt into the shower, that's okay. If that helps her feel safe and not exposed to someone, and then she can still wash as well as much as she can. Um, She's still cooperative with assistance, still washing her hair separately, but now sitting down as the sink is too high for her. It's not comfortable. It should be at the sink, actually. Success for Jane is that she allows assistance with her showering, continues to like showers, and is not afraid of the shower. And it also doesn't have to be all or nothing. Doesn't have to be that she has to do every part of the body. It may be just the lower part that she wants to shower and she's ready to get out, and that's okay as well. She may want to change the time of day, or she may want a couple of very short showers during the day. These are adjustments that are fine to make that can make Jane feel safe and comfortable. And the goals we may have had before for Jane to be able to be self dependent, be able to do things for herself. That's not the goal. The goal is to have her stay connected, to not be afraid, to be healthy and safe as well. And we know that people need to bathe for a variety of reasons for our health. Follow routine if it continues to work. You may want to add soft rhythmic music and maybe hum or move and sing with Jane in the shower. Contrasting colors in the shower to help locate Jane in space so she doesn't feel lost. Next slide, please. Okay, now she's into mid-stage. Now Jane appears frightened at the shower, reluctant to shower in the early evening, as in the past, and refuses to enter the shower at that time of day, sometimes asking to clean up when she returns from her day program. That's okay. Maybe it's not a shower every day. Note the amount of light and contrasting colors in the shower, as well as know her lifelong preferences. Increase or add a different light source. Avoid glare. Maybe it's a sitz bath. It's not the shower, but you wash down in the shower and she sits in the chair in the shower area. And you watch for incontinence during the day. And it may be a different time of the day that Jane now wants to shower. Give small choices. Would you like to use the lavender soap or the oatmeal soap? If she understood this before, and you may just show it to Jane for her to reach out to accept which one. Should we wash your hair today or tomorrow? These are all, it's okay to make these adjustments. And again, changes from what Jane used to be able to do are not signs of failure in your caregiving. Jane still being able to participate and still feeling safe and comfortable being connected to the world are signs of success. And we need to continue to look for those signs to feel good about the caregiving we do. Hand over hand technique. Instead of taking over, gently place your hand over Jane's and guide to wash yourself. Next slide, please. And stage 3. And you can see how physically Jane has changed. You can see the progression of the change that happens over time. Some of the changes does not get up in the morning to go to program, preferring to sleep in and then shower, wash up in the morning, as she's frequently incontinent at night. Then likes a calm breakfast, likes to take longer with breakfast. Or maybe she'd be willing to go to program if she can go a little bit later. maybe not have to take a long ride to get there, can be showered in the morning as well, and maybe finish her breakfast, have a little bit of breakfast at home, wherever home is, and then maybe the other half of the breakfast at the program when she gets there. In this case, Jane's family now transports Jane to program and picks her up in the early afternoon. She can't stay the full day, but she's spending a part of the day. That's success. She sleeps longer hours during the day she is home. She will take walks with mom or her sister when she comes to help mom. Next slide, please. So some days, no matter what you try, it won't work. This is late stage. That's okay. Forcing the issue will only create more fear and resistance for next time. Nothing wrong with using a washcloth to wash down. Option B, wash the key areas, face, hands, underarms, and private areas with a warm, wet washcloth at the sink. This is often much less scary than a full shower. There are also heavy washcloths that are made into gloves that can be used to wash down and brush that can, if they're warm, can feel very comfortable. Sponge baths in bed. For very resistant days, a no rinse body wash and a basin of water can be used to give a thorough sponge bath while the person sits in a comfortable chair or even stays in bed. Dry shampoo for cleaning hair between wet washes. It soaks up oil and leaves hair feeling fresh. Just skip it. If it's becoming a major battle, maybe it's changing the sheets and the clothes, and trying to clean up as much as you can with a dry cloth. Their mental well-being is more important than a perfect hygiene record. Try again later or the next day. Next slide, please. And by the way, there are some resources you can see on the side. Jane's baseline: serves herself, this is mealtime, selects her own food, uses utensil and dishes on her own. She has very strong likes and dislikes, expressing them often and refusing to eat food she doesn't like. Knowing the list of preferences and dislikes, and write them down, put them in scrapbooks, show visuals of them, which could be a tool that you use to show the visuals to Jane, who can then point to something that she wants rather than listening to the words, which she might not understand anymore. On weekends, Jane likes to sleep in and takes her time eating breakfast. She's a snack eater, and these are some of the things she likes. And once a week, Jane likes to go out with one of her siblings, mom, or meet friends from her program to a favorite family restaurant nearby. Next slide, please. So, beginning mild stage, she eats less of her food, demanding much smaller portions. That's okay. In fact, it's better to give smaller portions. I went out to lunch today with a dear friend who ordered a fish fry that I've never seen. It was literally on a platter, and she just sat there looking discouraged. And I was thinking, this is what we do for people with dementia: too much food, smaller portions, one at a time. Forks and knives may become more difficult to use, may need straws to drink both cold and hot beverages as well. So serve those smaller portions. Serve drinks first and then other foods one at a time on smaller plates and smaller amounts. If Jane forgets she already had a meal, it doesn't matter. Give her healthy snacks. In fact, the best thing you can do is break down meals into 5, 6 smaller portions of eating and understand that success that Jane continues to eat and continues to enjoy meals. Maintain the restaurant trips at different times of the day when not busy. Order the food ahead so less waiting time. May need more supervision while at the restaurant. Next slide, please. She may again eating less at meals and more snacks. That's okay. More foods she dislikes than likes. Difficult eating food and choking more when she eats. She may need to have an evaluation from someone to help you with the swallowing difficulties. Doesn't want to eat in the large dining room at her senior program, and very impatient at her favorite restaurant. May not be able to go to the favorite restaurant anymore. Maybe you need to get some dishes. I've done that with people, for example, who love McDonald's, but can't go anymore, not even to go to the drive-in and get the food. And so have had McDonald's donate their cups and plates and things with the logo on and serve the meal that Jane, in this case, might like on those plates. Might not even be the food from McDonald's, but showing them on the plates and drinks in the papers. That helps people to continue to feel that they're getting things they've had before and enjoy. Bake foods and meals, so smells help stimulate the appetite. Contrasting colors of plates to food, red, for example, to mashed potatoes and turkey. Placemats, chair with arms, chair with option for tray. Finger foods instead of foods using utensils. Eating, swallowing evaluation from a speech therapist may need a different consistency and type of food. Eating is essential, time of day matters less. Try to make it fun for yourself as well. Maybe mixing up food together. It doesn't matter if it's a little messy, as long as it's healthy, safe, and it helps Jane continue to eat. Next slide, please. At late stage, Jane is sleeping more often at her previous meal times. She's now can only eat pureed foods, not appearing hungry or asking for food. Eating the small amounts of food is important. It helps keep her connected to you as the caregiver. See each time she eats as success. Continue baking when possible, such as frozen breads and cookie dough. Ask for suggestion from dietitians at program, help from family and friends so you can take a break. Also, pureed foods, there are molds that you can mold the pureed foods in to make them look like the food. So if you have the smell of those foods and then have the pureed foods molded looking like foods, it will help Jane remember to want to eat these foods that she enjoyed in the past. Hand over hand assistance. Watch body language, determine if Jane is hungry. If Jane is sitting rocking, she may either need to use the bathroom or may be really hungry but doesn't recognize the pain of hunger. Try not to worry about mess. It's more important for the person to eat than to be tidy. It may help to wipe clean mats and covers and to have them covers over that can then just be picked up easily and washed. Nutrition and eating is also emotional and social for Jane and for you. It is very painful when you have a loved one that no longer wants to eat the food they used to. And it's something that feels, especially for mothers in particular, being a mother. I know that the first thing when one of my children is sick is the desire to get food into them, make sure they're taking food. Understand the disease causing the challenges and be kind to yourself and find fun ways to make that food more enjoyable for Jane, but also understand the refusal is not the refusal to you and your love. The refusal is because of the brain damage that's happening. Next slide, please. For all stages, as much as possible, protecting the dignity for Jane, but as much as for yourself as well. Distract and engage. Talk about something pleasant. Play soft, calming music, for example, in the bathroom. Be quick and efficient. Don't drag it out. Have a plan. This is in the showering for what needs to be washed. A quick, efficient shower is less stressful than a long, drawn out. What works today may not work tomorrow. That's okay. Take notes for yourself for that personal toolbox of how you can help support Jane. And if there's more of one of you as caregiver, share those notes with each other of what works. Next slide, please. Be kind to yourself as caregivers. You are important and need to care for yourself along the way. Your own health is essential. Having interests in friends, some respite time for yourself is also important. Look for who in your life can help. Sleep when your loved one sleeps rather than cleaning the house. Ask a family member to do the cleaning. There may be some respite services through a local provider. Hospice and palliative care may be helpful. Find moments of stillness, watch a movie together. Both of you have loved over time, an old comedy series, shared, remembered activities. Next slide, please. And here's a list of references and resources. At this point, I'm going to turn it over if anyone has any questions. Hopefully, my colleague Catherine and myself can help with some answers to your questions.